Hello, everyone. Welcome to today's webinar on methods for assessing the landscape of STI and HIV services in local health jurisdictions. Today's webinar is a part of a monthly webinar series hosted by RAISE and NASTAD. For those of you who may not be familiar, RAISE is the Research Alliance and Implementation Science to End HIV hub, which is a part of the University of Washington's Fred Hutch Center for AIDS Research. And NASTAD is the National Alliance of State and Territorial AIDS Directors, a national nonprofit that supports public health professionals working in local and state health departments. NASTAD is also the National Capacity Building Assistance Provider for CDC prevention programs in state and local health departments. We encourage you to learn more about both of our programs. We'll be putting some links in the chat shortly. And also reach out for scheduling a consultation if you're interested in learning more about how implementation science can support your EHE programs. We will also have a general email that you can reach out to if you have any questions about today's webinar. We will be sharing the recording from today's webinar on both NASTAD and RAISE's websites. And then just want to let you all know about our webinar coming up in November. That will be on Wednesday, November the 13th. And we will be having folks from HRSA, and we'll be talking about ending the HIV epidemic and the Ryan White program. So our presenters for today are going to be Roxanne Kerani, who's the Research Associate Professor in the Department of Medicine, Division of Allergy and Infectious Diseases at the University of Washington. We also have Chloe Morozoff, who is a doctoral student in the Department of Global Health at the University of Washington. Heather Mason, who's a Sexual and Reproductive Health Services Administrator at Public Health Seattle King County. Lisa St. John, who is the HIV and STI Prevention Program Manager at Spokane Regional Health District. And Kirsten Duncan, who's a Lead Disease Investigation Specialist also at Spokane Regional Health District. So I will now be turning it over to Roxanne to start us off.
Thank you, Krupa, and welcome everyone. I think we can just move right on to the next slide. So this is a quick overview of what we'll be discussing today. Krupa has already covered the introduction. I will be talking a little bit about methods for landscape analyses, as well as findings from some projects we did with 2 local counties here in Washington State, including Spokane County, represented by Lisa and Kirsten. Chloe will be describing work that she is doing involving patient feedback via discrete choice experiments. And then we'll do a panel with our local health department representatives talking about their experiences with completing these kinds of analyses with the UW team. And then at the end, we'll have some time for audience Q&A. Next slide. So diving into methods for landscape analyses, next slide. I'm guessing that many of you on the webinar, like me, are unfamiliar, or as I was when I started doing this work, I was very unfamiliar with landscape analyses and what they even were. So I thought it would be helpful to describe them and give everybody a chance to learn more about them before I dive into the methods. So the type of analysis is described very nicely in this paper by Garcia. It's a participatory research method for public health scholars interested in identifying and elucidating trends, opportunities, and gaps in a field. Next slide, please. Why might you want to do a landscape analysis? They can be done sometimes, often more rapidly than other types of research studies. They often use routine data that have already been collected for other purposes, and you can combine those data with data that you are collecting for the project in order to add additional impact. They most often don't require any sort of complicated statistical analyses. They're adaptable to different kinds of topics and settings, And similarly, the scale for landscape analyses can be very wide, such as being on the national level, or very focused on a smaller local context. Next slide. Landscape analyses typically use mixed methods, which can include both quantitative and/or qualitative data collection and analysis, literature reviews, or reviews of policies, guidelines, reports, laws, things like that that are available in whatever context you're working in. Next slide. For quantitative data collection and analysis, you might collect data through surveys or structured interviews, or again, you may do secondary analyses of already existing data. Qualitative data collection and analysis can include doing in-depth or key informant interviews or focus group discussions. Next slide. And they often involve a participatory approach, often but not always. And that approach can take varied forms, including local stakeholders in all phases of the work, from design to implementation and interpreting results. It can include collecting data from stakeholders or offering stakeholders in the local jurisdiction or whatever level you're working on the ability to provide input on interpretation and findings, or some combination of these three things. And you might ask, which stakeholders could it include? Next slide. The types of stakeholders that you can include in these kinds of analyses include local providers, either of medical services or social services, health department staff, community-based organizations, planning councils or community advisory boards, leadership of health departments or local healthcare systems, and community members. And on this slide, I've included the arrows going in towards the study team to sort of get at the fact that we're collecting data from all of these different kinds of groups or from some of these kinds of groups. Next slide. But then I also wanted to include arrows going out to indicate that often we take the data that we collect from people and then we push it back out to them to help to allow the stakeholders to have an impact on the interpretation of the data, as well as interpreting the findings of the project. Next slide, please. So now I'm going to be describing some results from projects, landscape analyses that we did at the University of Washington in conjunction with the Tacoma-Pierce County Health Department and the Spokane Regional Health District, focusing on both Pierce and Spokane counties, two counties in Washington state. Next slide, please. So to give those of you who are not located in Washington state some context, Pierce County is located just to the south of King County, which is where Seattle is located, while Spokane County is on the far eastern side of the state next to the Washington state, Idaho state border. Spokane County includes the city of Spokane, which is the second most populous city in the state of Washington, while Pierce County includes Tacoma, which is the third largest city in the state of Washington. Pierce County is also a part of the Seattle metropolitan area, and so there's a lot of kind of population movement between those two counties as people go into King County and come back to Pierce County and likewise. Next slide, please. For these particular projects, which were done as a result of funding from the Center for AIDS Research at the University of Washington, in conjunction with our health department's collaborators, we completed in-depth interviews with local stakeholders, which included physicians, nurses, pharmacists, healthcare administrators, people from all different kinds of organizations that provide STI and PrEP services, including community-based organizations. Using the data that we collected from those interviews, we identified both strengths and gaps in STI and PrEP services in those local areas. And then we generated recommendations to address those gaps, both from the study team, but also including recommendations that we heard from the stakeholders that we interviewed. We took all of that information and included or created a red cap survey, which we sent to subject matter experts at the local level, outside of the local county within Washington state, and as well as some subject matter experts at the national level. In the survey, we asked people to rank the gaps that we found in order of importance for the local county. And then we requested that they prioritize the recommendations that we generated for each gap to identify the most important recommendations to address those gaps. And finally, for dissemination, we presented our results to the local health department, and the health departments could invite other people from the local community if they chose. And we provided a final report to both health departments. Next slide, please. I wanted to give you all some sense of what the red cap survey looked like that we sent out to subject matter experts. This is an example of how we asked people to choose recommendations that would be suitable to address a given gap. So in this case, it was this was a gap about service availability, and people could choose any of these recommendations that they thought would work to address the gap. And then you can see at the bottom of the slide, we asked people of all of those recommendations, if you had to choose one or prioritize one recommendation, what would it be? Next slide. Oh, so the first set of questions we're getting at recommendation suitability, and then the last question is at the priority recommendations. Next slide. So now I'll describe some of the results that we found in Pierce County, and then I'll go on to describe the project in Spokane County. Next slide, please. In Pierce County, the strengths that we identified from our interviews were that providers who reported that they had a strong relationship, an existing relationship with the local health department, said that the relationship was beneficial to them in providing good STI care to their patients, and that the health department was very responsive to them. Providers also said that the partner services work done by the health department took some burden off of them because that way they didn't have to notify patients' partners. They also said that both at the health department and within the organizations represented by the people that we spoke with, that there was an open and accepting culture that made patients feel comfortable seeking STI care. Next slide. When we asked providers to rank the list of gaps that we identified in Pierce County, this was how they ranked the gaps. And I'll describe each of these gaps in a little more detail in the next slide, but you can see that the number one gap identified by the subject matter experts was service availability. Next slide. And 63% of the subject matter experts selected this as the most important service gap that should be or needed to be addressed in Pierce County. Next slide. So a little bit more detail about all of these gaps. That first gap was the fact that there was inadequate STI clinical services as well as PrEP availability in the county. The second gap was that there was lack of awareness of services among both providers and patients. The third gap was the fact that there were inadequate resources for uninsured patients or other patients who might need free or reduced cost STI care. Fourth gap was that these types of services, the delivery of them could be improved by better or stronger relationships, both between providers, but also between providers and the Tacoma Pierce County Health Department. Many people that we spoke with noted that the medical services in Pierce County are very geographically concentrated in Tacoma, but there's a widely distributed population, which made it difficult for patients who live in rural areas in Pierce County to access those services. And finally, referrals from one place to another were a barrier for patients who are seeking STI testing and treatment. Next slide. So that was Pierce County. Next, we'll move on to the work that we did with Spokane County, which was done in conjunction with Kirsten and Lisa, who are on the call. I hope that you both will feel free to jump in. Next slide. Some of the strengths that we identified in terms of STI and PrEP service delivery in Spokane County were that people who reside outside of Spokane County, both in Washington counties other than Spokane County, but also on the Idaho side of the border, rely on Spokane County's STI services because they don't have those kinds of services or access to those services in their own jurisdictions. Providers in Spokane County also reported that the health district is responsive and helpful to them when they request information or need other support, and also that they rely on the Spokane Regional Health District for technical expertise around both STIs and PrEP. Next slide. The gaps that we identified in services in Pierce County are shown on this slide, and here they've already been ranked by the subject matter experts in order of importance. So the first one, again, was availability of STI clinical services. The second one was accessibility of STI and PrEP services. And in this one is sort of wrapped up that geographic concentration of services in one place versus a more distributed population. The third gap was that the health department and providers all have limited capacity to provide STI services and PrEP, that there were gaps in prenatal care, especially for women from marginalized populations, such as those who are experiencing unstable housing or substance use. That stigma impacts the engagement of marginalized populations in STI services in Spokane County, including the women mentioned in gap number 4, as well as MSM and transgender populations. Providers in Spokane County could benefit from additional training or increased awareness of local STI and PrEP services. That the cultural context in Spokane County inhibited the engagement of patients in STI services because they felt that STIs were stigmatized, and that there are an inadequate number of PrEP providers in Spokane County. Next slide. So I wanted to just give you a sense of the information that we provided in the final presentation we did to the health department, as well as our final report. This is some of the information that we included for their first gap, that the availability of STI clinical services is inadequate in Spokane County. We also looked at some surveillance data and how many or what proportion of urethral gonorrhea diagnoses were occurring in emergency rooms and urgent care settings. And we found that that proportion was higher than it seemed like it should be. We heard from our stakeholders that there was insufficient availability of STI specialty care. And then for each gap, we included 1 or 2 quotes from our stakeholder interviews to support that gap. And here the provider was talking about the fact that there just aren't enough services or places to go where people can be seen quickly. And they said, of course, in Spokane, you know, in our emergency room, if you go in with a broken toe, you're going to wait for about 6 hours. Next slide, please. Some of the recommendations that we included to address that gap included creating a brick and mortar STI specialty clinic in the county, to provide training for primary care providers to increase STI screening across the county, to fund additional STI specialty services in existing clinics. And then we also provided subject matter experts with the opportunity to list other recommendations in the survey. And so for some of these gaps, we did receive quite a few other suggestions. Next slide. The Spokane Regional Health District also decided that they wanted to use some of the funding that they received as a result of this project to do some work with patients, which we thought was a great idea because it helped kind of triangulate the information that we were hearing from providers to hear more from the patients about the barriers that they were facing. So we developed a focus group discussion guide collaboratively with Lisa and Kirsten. They recruited participants and conducted the focus group discussions in Spokane. They were able to incentivize participation in the focus group discussions with the funding that they received from the Center for AIDS and STD. And they decided to focus on 3 groups of participants: MSM, women who use substances, and adolescents. I think adolescents was actually young adults. Next paragraph, or next slide, please. This slide shows some of the findings from the focus group discussions. And I just want to point out that a lot of these do echo the gaps that were identified through our stakeholder interviews. So for example, the second row, all of these patient groups said that lack of transportation in the county was a barrier to accessing services, which echoes our number 2 gap, lack of service accessibility. You also see some notes here from the women about poor treatment at ERs, urgent cares, and prenatal care settings. And then from MSM, the fact that primary care providers aren't comfortable providing care to MSM, getting at those gaps around stigma and the conservative culture in Spokane County. That is all that I have to share with you today. So next, I will turn it over to Chloe.
Great. Thanks, Roxanne. Hi, everyone. I'm Chloe, and I'll be speaking about an ongoing landscape analysis project with a client survey add-on that we are conducting in South King County, Washington. And this project is a collaboration between UW and Public Health Seattle King County. And we have Heather Mason on the call, who can also speak to the project as well during the panel. Next slide, please. Great. So our project aimed to identify opportunities to improve STI care and other SRH services in South King County, Washington, which is the neighborhoods right below Seattle. And the rationale for this project, we've seen bacterial STI increases nationally and in King County, especially with the syphilis epidemic. We also know STIs have a disproportionate impact on racial and ethnic minorities, as well as uninsured folks. And South King County is particularly at risk of STI treatment gaps because we have a lot of population growth happening in those neighborhoods, especially among immigrant populations, which can result in strained services. And there's also a higher concentration of people living below 200% of the poverty line, which is demonstrated in the darker blue portions of the map in the upper right corner. And these clients are more likely to be safety net clients who are on Medicaid or are medically uninsured. Next slide. Great. So we had 2 aims for this project. The first was to identify and describe the landscape of STI services provided in South King County and solutions to bridge gaps in care for vulnerable populations. And then the second aim is to determine patient preferences for accessing and receiving SRH services and how those preferences align with current service availability in South King County. Next slide, please. So I'll briefly talk about the first aim. Next slide, please. So the first aim really is a landscape analysis. I'm just going to briefly cover this since Roxanne did a great job of talking about landscape analyses. So for this project, we conducted key informant interviews with 12 STI service providers that provide care to clients in South King County, and we really focused on safety net providers. We then conducted rapid qualitative analysis to identify strengths and challenges with service delivery to try and source suggested solutions to improve care at different levels. And then different from the landscape analyses that Roxanne described, we also had a portion of our project that focused on exploring client barriers and facilitators for accessing care. So we asked service providers, if they've heard any requests from clients like, can you expand your operating hours because we're having trouble accessing services during your operating hours, or talk about changes that they've made to their facility that have improved access, things like that. And that was used for our second aim, which I'll be talking about next. And then lastly, we are in the midst of doing a quantitative ranking survey, similar to what Roxanne described, and that's in process, so I won't be talking about that. Great, so for the second aim, this is what I want to focus a bit more on. This was an add-on that we did to our landscape analysis that focused on determining patient preferences for accessing and receiving SRH services and seeing how those align with current service availability. Next slide, please. And for this aim, we used a discrete choice experiment methodology. And this method originated from the economics field and is really used to explore consumer preferences when they're faced with different options and the need to make trade-offs. So historically, this has been used a lot for developing new drugs, asking people to compare different drug profiles, select their preference. So an example of this is like asking clients, would you prefer an injectable drug with higher efficacy that causes headaches, or would you prefer an oral drug with lower efficacy but no side effects? And then kind of repeating that experiment, changing the profiles, and really trying to get at like what do patients prioritize when they're selecting a drug. So that's kind of the background on the method. There's different things that you can learn with this method. You can learn general preferences. So for example, you can learn things like, do clients prefer to have an appointment in the evenings, or do they prefer to have a medical appointment on the weekend? You can also understand things related to relative preferences. So what do clients prioritize when they have to make trade-offs between their preferences? For example, if they want to access a health facility close to their house that has walk-in availability, but that doesn't exist, will they make an appointment at a nearby facility, or will they travel further away to access walk-in services? So what preference do they prioritize? And then lastly, you can assess willingness to pay. And this can be in relation to money, but can be in relation to other things like time. So for example, how willing are clients, or how far are clients willing to travel to access something like walk-in testing? Next slide, please. So for our project, we used our landscape analysis to identify important service attributes for STI testing. And then we piloted these attributes with clients, English and Spanish speakers, to see what resonated. And the final attributes that we selected for our project are listed here. They include locations of STI services. So for example, the type of clinic or a community location, travel times to clinic, hours of operation, methods of making an appointment, and testing fees. And I know this is potentially hard to conceptualize, so I'm going to walk you through an example of a survey question. If you could go to the next slide, please. Okay, so you can see here, this is a screenshot of our survey. And you can see that there's two options that are shown vertically. There's an option 1, and then next to it, there's an option 2. And at the bottom of the screen, there's a select button. So clients are asked to review option 1, review option 2, and then select which option they prefer. Next slide, please. So if we focus on just option 1, you can see that there's the attributes that I mentioned on the left side, and then the options are listed in option 1. So option 1 would be you go to a health clinic, a doctor's office that's pretty far away from you. It's about an hour away, and it's open during business hours as well as on Saturday. You have to schedule an appointment, and you would do that by phone. And then you would pay $15 for your test, your STI test. Next slide, please. Option 2 is pretty different. So this would be, you would be tested for STIs at a community location, like a library or a health fair. This location is closer to you. It's only 30 minutes away. It's not open on Saturdays, but it is open weekdays during the day and on evenings. Again, you have to schedule an appointment, but this time you would do so online rather than on the phone, and you would have zero fees for your STI test. Next slide, please. So when you look at these two options, you can think to yourself which one you would prefer. I know for me as a PhD student, I really value my time and I have limited resources. So I would probably select option 2 because it's closer to me and it's free. But for someone who doesn't have flexible work hours, they might really need to access care on the weekends, or maybe someone really doesn't want to be tested at a community location. They don't find it as discreet. They might select option 1 and be willing to travel further or pay more money for option 1. So this is an example of one question that clients are asked in this discrete choice experiment. We would then, once clients select option 1 or option 2, the experiment would reset, and option 1 and option 2 would look really different. They would show different attributes. So option 1 might now show like a community location that has like a $40 test fee and is really close to their house. And basically you would keep repeating this over and over, 12 different times, showing the different combinations to see what clients are really prioritizing. Next slide, please. So we are launching this survey. It's a tablet-based survey with a $20 incentive. It takes about 10 to 15 minutes to collect the data. And it is being implemented at South King County public health clinics and a few other community settings. And the goal is to have a sample size of 250 with a minimum of 50 Spanish speakers. I'm happy to say we recently launched the survey and we've conducted about 20 different surveys. Next slide, please. Great. So taking a step back and thinking about how we can combine these client survey findings with our landscape analysis, I think there's two primary ways. The first is looking at how client priorities align with current service availability. So for example, if we see that clients really prefer weekend appointments, from our landscape analysis, we'll be able to say how many safety net sites actually offer weekend availability. The second way is that allows us to align implementer solutions with client preferences. So for example, one barrier that came up in our landscape analysis is that South King County is really spread out. Public transit is quite challenging, especially east-west. And so one of the solutions that was very commonly raised was to offer more community-based testing closer to where clients live. So adding on this client survey, we can add on the client perspective and say, how willing are clients to actually access testing at the community versus a clinical setting? Or for example, how far are they willing to travel to different locations? So you can select where to do your community sampling. So it really allows you to say, are certain implementer solutions from the landscape analysis likely to be effective? Will they lead to increased STI testing, access and uptake? And I think that's all from me. Roxanne, I think it's back to you now.
Yes, that's right. But Chloe, I would invite you to jump in on the lessons learned slide. We just wanted to talk a little bit about some of the things that we've picked up as a result of doing several of these landscape analyses in local counties here in Washington State. I think that collaborating with our health department partners allowed us to do a better job of identifying both important stakeholders, but also stakeholders who were willing to talk with us. And in some cases, we relied on our health department collaborators to follow up with the stakeholders if we hadn't heard back from them. And that sometimes that helped us get some of the interviews that we really wanted, when people weren't necessarily responding to us. We have also found that surveys have to be very focused and to the point, and can't be too long or they don't get done. And then this has come up in almost all of these projects. There may be more gaps than are really feasible to put into one of these surveys to ask subject matter experts to rank and think about recommendations. And so one of the things that we ended up doing for, I think, the first time with the Pierce County project was to identify a list of primary gaps, which we defined as the gaps that were most often mentioned by a variety of providers, versus secondary gaps, which may have come up a couple of times, less frequently, and by fewer providers. And so for our subject matter expert survey, we told people that they had to answer the questions about the primary gaps, but then they could weigh in on the secondary gaps if they chose to, but they didn't have to. Chloe, is there anything that you want to add here?
No, I think that's great. I'm sure the panelists can also add their experience too during the panel portion.
I think that's right. And so I think that we can move on to our panel with Lisa, Kirsten, and Heather. If you all want to take yourselves off of or bring yourselves on camera, great. Thank you. I have some questions for you all, and we'll just walk through some of these questions. The first question is for Lisa and Kirsten. As I noted, you all did focus groups as part of your project. Can you talk a little bit about the value that you think those focus groups added to the results of the project?
Yeah, I think our focus groups really provided an additional voice to really understand if what the provider perspective aligned with the community's perspective. And so I felt like it was an important piece to include in this to really understand what is the patient experience and what did they view as the primary gaps when they're attempting to access care.
Great. And a follow-up question to that, how did you decide on those three populations that you did the focus groups with?
We focused on identifying the populations that are disproportionately impacted by STIs in our community. So looking at MSM, they have higher rates of HIV and syphilis. Our women who are substance using contribute to the majority of our congenital syphilis cases and are disproportionately impacted by syphilis. And then our adolescents account for a large proportion of our gonorrhea and chlamydia cases. So really understanding the experience of those that are most impacted by STIs in Spokane County.
Great, thank you. Okay, now I'll open up the floor to all three of you. What do you all see as the potential benefits of landscape analyses from the health department perspective?
Roxanne, I think I could respond to that one.
Go ahead.
Really, there were three large things that came out of this experience, and it was a year-long experience. We had a chance to work with a professional academic team to do an analysis of essentially our market, our community. What do our customers need? What do they want? We were able to learn not only what our customers wanted and needed, but what many of our colleagues thought were the gaps and what they wanted and needed. And the third thing, and this is probably more of an operational thing, but as anybody who works with funding or navigating any kind of a healthcare service, we know that funding's not always available, and when it does come by, we have to act quickly, and we have to have adequate data to support what we're asking for. So now I have a professional, non-biased report that I can share with governance and my health district administration that demonstrates that public health clinics or more clinical services is not duplicative in our community. That's all I've got on that one, but it's going to be very, very valuable.
Thank you, Lisa. Heather, is there anything that you want to add on this one?
Yeah. Lisa, I can't wait until we get our results for some of the exact same reasons. Well said, and thank you. Yeah, I want to echo the value of landscape analysis in general. I think it really helps, as you all stated, in identifying those gaps. And I think in doing that, really illuminates the health disparities within either a geographical region or population. So it's another essential data point on the ground, like what's happening in these communities that might be contributing to the notable health disparities that we see already in these spaces. And so I find that incredibly invaluable. And similar to Lisa, I feel like this information supports us on so many levels, and a lot of it is internal information and education / advocacy to change these systems, to try to get more resources. So on all levels, from leadership within public health to collaborating with partners around shifting healthcare in a way that better meets patients' needs when applying for grants to demonstrate the need, as well as looking at policy and system changes and making recommendations. I find this information will be really helpful on all of those levels.
Thank you, Heather. So you both have touched on this to some degree, but how have you used, or do you plan to use, the results from these projects? Anything you want to add on that topic?
I just will add one more thing, even though I kind of already answered it. I also think it's really important when conducting projects like these, where we are receiving information from folks, that we are, and you spoke to this, Roxanne, we're also reporting back, right? This is also of value to our partners that we have interviewed, are working with, so that they know they can benefit from this information as well. And I think that's how collectively we are going to be able to move this work forward.
Thanks, Heather. And on that note, when we completed our projects in Pierce and Spokane counties, we sent the final report out to all of the stakeholders that we interviewed in order to give them the results, that after they so generously participated and gave us their time, we felt that it was important to share the final results with them. So you all collaborated, as you noted, with us at the UW, but also with other local stakeholders. Is there any particular value you see in collaborating across these different kinds of stakeholders?
I think so, yes. I think that it strengthens our understanding of the provider experience in our county. It's not something that we independent in our health department could have done. And so to have that level of engagement with our providers, to understand their perspective of sexual health services, what we here at the health department can offer, and maybe where we can improve things internally, but also just having a shared understanding of our barriers and access to care, and where as a community we can move forward. So I work really closely with healthcare providers in my day-to-day work, and I often think about our results from this study and bring that into that work with folks. And so how can we improve sexual health services now without maybe expanding access to funding at this point, but how can we still think about those really most identified gaps in a way that we can work together to improve services based on what we have now?
Great. Thank you, Heather. Anything you want to add there?
Sure. I mean, I think first and foremost, I think the traditional silos and scarcity mindset of healthcare has put us in a position where it is sometimes hard to collaborate. And I think these type of projects really bring together the possibility to really address health inequities, because there is plenty of work for everyone at this table. And I really appreciate when you said that, Roxanne. And I think, Lisa, you mentioned that earlier. It's not duplicative work. right? So how do we come together more collectively? How do we leverage existing resources, share best practices, evidence-based, without the traditional and institutional structure that has prevented that from happening and has really resulted in some of these negative outcomes that we are trying so hard to avoid, right? And so I do find value, and I look forward to a community, a table, a larger table to look at STI care. And I think there's been some great examples with the Ending HIV Epidemic Healthcare Collaborative that Matt Golden and Sarah Magnuson has been providing one table to have these discussions. And I think this information is valuable there, and really just continuing to expand that table, because we really just all want the same outcome for our patients to have access to high quality, equitable care ultimately.
Thanks to the three of you. Anything else that you would like to add before we move on to the general question and answer time for the webinar? No? Okay. With that, I will open it up to questions from the audience. Emma or go ahead.
Oh, sorry. I was just going to say, I don't see any questions in the Q&A or chat. So folks can feel free to also unmute if they'd like to ask their question live.
Sounds good. Thank you, Krupa. One thing that I neglected to mention was that we are also doing a similar project, similar to the earlier ones that I described with the Yakima Health District now in Yakima County in Washington. So it will be exciting to see what we come up with there. We've gotten to the stage where we've interviewed stakeholders and we've developed the survey, and we have survey results coming in from subject matter experts now. I see, Matt, you have your hand up.
I was wondering if you guys have thoughts about how we can get this kind of information in front of policymakers. You know, we've done quite a bit of this now, it seems to me, within Washington State, which is funded through CFAS. And it, you know, and I think it's time to try to convert it into action. So how are we going to do that?
That might be the million-dollar question.
Matt, I appreciate your question. I'm going to start at a grassroots level, thinking about key stakeholders within the Department of Health who have their own internal mechanisms with which to get things pushed forward through legislative sessions, to other groups that have the same vested interest elsewhere, who have the capacity and leeway to, within the scope of their work, provide more advocacy efforts as well. So I tend to try to go through different organizations, go through different entities to disseminate and make recommendations like we do. And I think that that's one pathway that I am familiar with and would imagine doing with this as well.
I will say, Matt, that we've been sharing these results with our colleagues at the Washington State Department of Health. But I think that really we need to figure out a way to push them up even higher so that there is funding, because that, I think, is one of the huge barriers in creating more services or more accessible services, is just not having the funding to do so.
Yeah. I think one thing we also might think about, and I'm interested in what other people who are on this call, if they have advice for us, these organizations like the Washington State Medical Association, the Health Officers Organization, things like that. I think, you know, they may not be aware of this, you know, since it was really something that came out of the university to try to push government in a certain direction. But I think they could be our allies, and those sorts of organizations exist in most states.
I think that's a great idea. Is there anyone on the call who has had experience doing something like that, sharing information with groups like these in their state or local jurisdiction? feel free to just take yourself off of mute.
I do some consulting work for the Shelby County Health Department in Memphis, Tennessee. And they have been working with an organization of Black doctors in town since most of these, the disproportionate impact in that community, and have had some initial success in that way.
That's helpful. Thank you. Thanks for that question, Matt. Does anyone else have any questions or comments?
Hi, Dr. Kerani. I'm Carrie Venus with the Mountain West AETC. I'm the Central and Eastern Washington coordinator, and I just want to tell you we are so excited for the results of the gap analysis for Yakima to come out. My colleague Victor and I are starting some work with the Yakima Neighborhood Health Services. They currently don't have any prevention and treatment for HIV set up in their system, and we're really excited to get the ball rolling, and the gap analysis will help inform us where we need to start in that area. So thank you.
You're welcome. And we would be happy to share the results with you when we're done with the analysis. Yeah, it's definitely been interesting to see kind of the similarities between the health departments, but then there have been some very striking differences too. And I think HIV care and prevention in Yakima in particular is, there are more barriers to it in Yakima County than in the other counties that we've worked with.
Yeah, thank you.
Nat?
Yeah, I thought I'd just make one other comment particularly for the people who are sort of academic types on the call, is the way we funded this was through something called a New Collaborations Grant from our Center for AIDS and STD. And the idea here was really to have the University of Washington, use its expertise to form new collaborations related to public health practice around the state. Since a lot of what we've done traditionally is focused on King County, but we're a state university. We are not the University of Seattle. And so it was really important to get out of Seattle for some of this work. And, I don't know who else is on the call in terms, or the group from university side, but I do think this is a kind of a niche that we can potentially play to support public health.
Any other?
Go ahead.
I was just going to say, any other questions from the audience? If not, we can wrap up for the day. Okay, well, I just want to say a big thank you to all of our presenters today and to everyone on the call. Do join us for our webinar in November, on November 13th, and feel free to contact us at the contact email that Krupa just put in the chat if you have any questions that occur to you later. All right.
Thanks for joining us, everyone.
Thank you.
And a big thank you to Lisa, Kirsten, and Heather as well.
Thank you.